today, as Professor Hatem said, is EMG, and nerve conduction studies in radiculopathy. As you all know, EMG plays an important role in the evaluation of radiculopathy, although imaging has a pivotal role in visualizing the spinal cord, nerve roots, and the relationship to the vertebrae and intervertebral discs. But the functional imaging, the condition of the nerve and the muscle, can only be given by the EMG and nerve conduction studies. Besides being of functional assessment, important in the functional assessment, in many cases of radiculopathy, the MRI will be normal, and we need EMG to point out the presence of radiculopathy. This is in cases of infection, demyelination, as in EIDP, for example, infiltration, such as cases of lymphomatous meningitis, or any malignant infiltration, or in cases of infarction, infection as Lyme disease or herpes simplex. So EMG is indispensable in cases of radiculopathy. So it complements MRI in localization as well as functional assessment. As you all know, the clinical hallmark is pain and paresthesia along a certain nerve root. This is very famous. The patient comes complaining of pain and paresthesia. There is also sensory disturbance. I say sensory disturbance, I didn't say sensory loss, because in cases of radiculopathy, the dermatomal supply, which we will see, is characterized by an overlap. There is overlap of dermatomes. This overlap of dermatomes will result in sensory, maybe abnormal sensation, sensory affection, sometimes vague sensation, but it will not be a deep and marked sensory loss, as we said, because of the dermatomal overlap. If there's such extreme sensory affection, we have to think about a peripheral or a proximal nerve affection, not a radicular affection. Paraspinal muscle spasm is frequently seen. It's frequently affecting the neck, and it's very characteristic in cases of cervical radiculopathy. Motor dysfunction is also present, but as there is a dermatomal overlap, there's also a myotomal overlap. The muscle has motor supply from more than a nerve root, so I cannot expect the muscle to be completely paralyzed in cases of radiculopathy. There are degenerative changes in the vertebrae causing radiculopathy. There are common sites for such findings, which is from C3, cervical 3 to cervical 8 in the cervical region. In the lumbosacral region, it's commonly in L3, L4, L5, and S1 roots. This will cause what we can describe as common cervical root syndromes in the cervical region and common lumbar root syndrome in the lumbar region. So let us go through clinical picture of common cervical syndromes and common lumbar syndromes to revive our memory about the complaint of the patient. A patient with C3 and C4 root affection will complain of pain in the paraspinal muscle and superior shoulder region. The sensory affection will be in the neck, the vague sensation we talked about. The weakness is mainly in the diaphragm and nuchal muscles, and there's no reflex that I can test to make sure I have C3 and C4 radiculopathy, because I have to have a muscle supplied by these routes that is accessible for reflex testing to have the reflex change, which is not the case in such a condition. But in C5 and C6 radiculopathy, the biceps and the brachioradialis reflexes are affected. The pain is mainly in the neck, shoulder, and anterior arm regions. In C6, the pain is extending to the antecubital fossa. In C5, the sensory affection is mainly in the shoulder area. In C6, it's in the thumb, index finger, and radial forearm. Weakness for C5 and C6 radiculopathy is in the deltoid, supraspinatus, infraspinatus, rhomboids, biceps, and brachioradialis muscles, with pronator teres, flexor carpi radialis, and extensor carpi radialis muscle affection in C6 radiculopathy, on top of the previously mentioned muscles. C7 radiculopathy is the patient has pain in the neck, shoulder, and dorsum of forearm, and the sensory disturbance is mainly in the middle finger, with weakness in the triceps, latissimus dorsi, pronator teres muscle, as well as the flexor carpi radialis and extensor carpi radialis muscles, and the triceps reflex might be knocked down. C8 and T1 radiculopathy, the pain is in the neck, shoulder, and ulnar forearm for C8 and ulnar arm for T1. There's no particular reflex to test for these for these root values. The affection is in the intrinsic hand muscles, and for the C8, it's in the finger extensors and finger flexors, with a possibility of Warner's syndrome in T1 affection. Sensory disturbance is in the ring and little finger and hypophenar eminence in C8 affection, and in T1 it is in the ulnar forearm. Some commonly encountered lumbar root syndromes are L3 affection and L4 affection. The pain location here is mainly in the anterior thigh, with groin affection in L3. We can test with the knee reflex. The knee jerk is affected in these cases, with weakness in the iliopsoas, adductors, and quadriceps femoris muscle. The sensory disturbance is in the anterior thigh in L3, and in the medial calf and medial foot in L4 radiculopathy. L5 radiculopathy, the pain is characteristically located in the posterolateral thigh and calf, extending into the great toe and dorsum of the foot. The sensory disturbance is in the dorsum of foot, great toe, and lateral calf, and the weakness in the tibialis, anterior and posterior muscles, and extensor hallucis longus, the peronei, gluteus medius, and fascia lata. Lastly, not least, because it's very common, the S1 with pain in the posterolateral thigh and calf, toes and heels. Sensory the lateral foot, posterior calf, sole of the foot, with the ankle jerk, which is commonly knocked down, and of course the is the electric counterpart, and the weakness is in the gastrosoleus, hamstrings, and gluteus maximus muscles. These were the common lumbar and cervical root syndromes, and excuse me, I had to go through all of them in a lot of details, because they're frequently encountered, and we have to point down the clinical picture. We have to talk about clinically and not rush into electrodiagnosis right away. As I said before, there is a profuse overlap of dermatomes, but the main supply of dermatomes is beautifully illustrated in this slide. I loved it because it's easy to recall, easy to remember, because it starts with C3 here, and we go down with all cervical roots. Then we go up with the T1 till T12 roots, then L1, L2, L3, L4, L5, and as you know, here comes S1 and S2. This, as you all know, is the position of, or how the fetus is developed. Therefore, this position the man is encountering, if you visualize it, you will be able to record the dermatomal supply without having to learn it by heart. The overlap of myotomes is also important. I wanted to put it separately here before we talk about the electrodiagnosis, because knowing the main muscles in the upper and lower limbs as regards the muscle itself, of course, the muscle name and how clinically, which nerve supplies this muscle, and the root value for this muscle. This data is a lot, but there's nothing we can do about it, because this is very important, as we will see in the EMG and nerve conduction studies protocol, what we will exactly do. We have to know that each muscle has a certain root value, and at the same time is supplied by a certain nerve. I mean that the root value might be the same, but the nerve can be different. For example, here, flexor pollicis longus is C81. Here it's supplied by the median nerve. Here C81 flexor digitorum profundus, it's supplied by the median nerve. This is very important for the algorithm, where we will definitely point out to the diagnosis of radiculopathy and the differential diagnosis. I can quickly go through the muscles and nerves if you think it's okay. Shall I go quickly through the muscles, Professor N?
No, I think it will take a long time. It's better to go directly.
As you wish, I can do it quickly.
As you wish, as you like.
Okay. I just wanted to make sure that every operator can do a test for a certain muscle to serve a purpose, while another colleague does the test through testing another muscle and reaches the same goal. So it's a matter of preference, but there are very important muscles that are like a joker. They will solve a problem for me, and testing these muscles is indispensable. I will just quickly go through the muscles. The rhomboid muscle supplied by the dorsal scapular nerve, the root value is C5. Here are a large group of muscles supplied by with root value C5 and C6 innervation. Here the underline means mainly C5 or mainly C6, while the supraspinatus and infraspinatus are supplied by the suprascapular nerve, the deltoid by the axillary, biceps, brachii, and brachialis by the musculocutaneous. As for the radial nerve, it supplies the following muscles, where the root value is C6 and 7 for the triceps. For the anconeus, it's C6 and mainly C7. For the brachioradialis, it's C5 and mainly C6. And extensor corpi radialis, it's C6 and mainly C7. While the last two muscles, extensor pollicis brevis and extensor indicis proprius, are mainly supplied by C8. In the median nerve, pronator teres and flexor corpi radialis muscle, root value is mainly C6 and C7. Flexor pollicis longus, pronator quadratus, abductor pollicis brevis, the root value is mainly C8 and T1. For the ulnar nerve, all muscles have a root value of mainly C8 and to a lesser extent T1, except the flexor corpi ulnaris muscle. The rest of the muscles have a root value of mainly C8, namely flexor digitorum profundus, abductor digiti minimi, abductor pollicis, and first dorsal interosseous. For every electromyographer, as I said, there can be a preference for doing this muscle and that muscle, but at the end you have to solve the problem and reach your final diagnosis. In the muscles of the lower limbs, the iliacus, the nerve is from the lumbar plexus itself with the root value L2, 3, and 4. Adductor longus, the obturator nerve, L2, 3, and L4. Tensor fascia lata and gluteus medius and gluteus maximus. The nerve is the gluteal nerve. Both have root innervation from L5, but gluteus maximus has the main innervation root value from S1. The femoral nerve, vastus medialis and lateralis, and the rectus femoris muscle, the root value is L3 and L4 mainly, and L2 to a lesser extent. Fibular or perineal nerve, the muscles are biceps, the short head of biceps, and this is very important because the main innervation is it takes from L5 and S1, but mainly S1. So this is an important muscle in solving our puzzles. The anterior tibialis from L4 and L5, and the extensor hallucis, peroneus longus, and extensor digitorum brevis take from L5, S1, but mainly L5. For the tibial nerve, the semitendinosus and semimembranosus are supplied by the sciatic nerve, L5, S1, semitendinosus mainly L5, semimembranosus mainly S1. Biceps femoris, the long head, root value L5 and mainly S1. Posterior tibial L5 and S1. Flexor digitorum longus L5 and S1. A lateral head of gastrocnemius muscle, another very important muscle, the root innervation is S1. Gastrocnemius, the medial head is mainly from S1 to lesser extent the one before and after. The soleus muscle mainly from S1, and abductor hallucis from S2 mainly, but also from S1, and the abductor digiti quintipedis from S1 and S2. For the electromyographer, it's okay to have this table on the side. You have to have a manual at your fingertips because sometimes it is really challenging and you might need one of these muscles, maybe one that you are not examining frequently. So it's okay to have a manual or an atlas at your fingertips. What can cause radiculopathy? The most common causes are structural lesions, as we said, disc herniation, degenerative changes, bony impingements. The less common is the radiculopathy at a microscopic level, the infarctions, the infiltrations, rarely due to EIDP, Guillain-Barré syndrome. Nerve root infarction can occur in cases of diabetes. It's not uncommon, it's something frequently encountered. Differential diagnosis of pain and radiating paresthesia. As we said, the pain and the radiating paresthesias are the hallmark of in the clinical diagnosis. So number one is radiculopathy, but the same can occur due to proximal neuropathy, plexopathy, and entrapment neuropathy. And this is the challenge of the electrodiagnosis. EMG plays an important role in the evaluation of radiculopathy. MRI, as we said, is diagnostic in radiculopathy due to structural lesions in infection, demyelination, infiltration, or infarction. EMG is important and it will add to the diagnosis. Sorry.
شكرا دكتورة أميرة. ده كده.
No, I didn't finish. No, 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 no.
Not yet. Not yet.
I have a problem with the presentation.
Okay.
Hold on for a second, please. I stopped sharing. Okay, I can start again, right?
Yes.
Okay.
Yes.
The show didn't begin yet, Dr.
Okay.
Khatem, but I don't know where my slides are. What shall I do? Let's try.
Okay,
Reshare.
take your time. Take your time.
I didn't know where it went. New share, right. But I can't find my presentation here. What shall I do? Open it on the desktop, maybe?
Yeah.
Right?
Take your time, Dr. Amira. We are waiting for you.
We can see your computer. We are with you.
Really?
Yeah, we can see the computer now.
Excellent.
Yeah, full screen. And
you can
begin.
see it now?
Yes, full screen and begin.
Okay. Let's quickly. Yes. Sorry about that. Yeah. What's the goal of electrodiagnosis in radiculopathy? It can confirm the presence of radiculopathy, establish the involved nerve root level, and hence the importance of the very lengthy talk about the myotomes and the root value of the muscles. It can, of course, help in pointing out any axonal loss or conduction block if present. It can grade the severity of the condition, and it can estimate the age of radiculopathy. When did this condition or this radiculopathy, when did it occur? And it's important in excluding other peripheral nerve diseases that mimic radiculopathy. Nerve conduction studies are typically normal in radiculopathy. It's important to differentiate between radiculopathy, plexopathy, and entrapment neuropathies. Plexopathies are not as common as radiculopathy, and these are the most difficult to differentiate, but entrapment neuropathies are easy to differentiate from radiculopathy. That's why we, in the upper limb, we have to exclude carpal tunnel syndrome and ulnar entrapment, and in the lower limb, we have to exclude peroneal neuropathy. Why? Because these conditions typically can mimic the radiculopathy, especially if mild. If mild radiculopathy or mild carpal tunnel syndrome or mild ulnar entrapment, it might mimic the mild or the early radiculopathy, and the same condition in peroneal neuropathy. If the condition is having its full-blown picture, then the mix-up will not be a very big problem. What shall I do? I shall do motor studies, sensory studies, late responses, the F wave, and the H reflex. What's the exact protocol? What shall I exactly do? Motor nerve tests. How are these done? Of course, you are now, you have gone through many fruitful lectures. So you all know that motor nerve tests are done using what's called supramaximal stimulation. When doing a test for a motor nerve, I measure distal latency, which is measured in milliseconds, the amplitudes, which is measured in millivolts, and the nerve conduction velocity, which is measured in meter per second. In the upper extremity, I have to test for median, ulnar, and possibly the radial nerve. In the lower extremities, I have to test the peroneal and the tibial nerves. As for the F wave studies the proximal roots, antidromic motor, the anterior horn of the spinal cord, and orthodromically to the muscle. It's a pure motor test. A prolonged asymmetric F wave suggests a proximal root lesion. Clinical application in cases of plexopathy when I do the F wave, a quite prolonged F wave means there is demyelination, such as AIDP, or a mild prolongation denotes axonal injury, because of course, as you all know, the demyelination affects the conduction, in this case of the F wave, prolonged F wave, and the axonal injury affects the amplitude. But it's less sensitive than EMG for radiculopathy because only a short segment of the nerve is demyelinated in radiculopathy, and hence the effect of demyelination will be limited. As we said, the commonly affected roots in the upper limbs are C5, C6, and C7. When I do the ulnar and the median F wave, they will not be reflecting an abnormality. If the lesion is in C5, C6, and C7 only, then a median or ulnar F wave might be known. This is not the case in the lower limbs, where the affection is commonly encountered at L5 and S1, so the peroneal and tibial F wave will be either prolonged or absent, or I will compare both sides and find an abnormality in the affected side, so it will be of great value in the lower limbs. As for the H reflex, it's a reflex loop. Orthodromic sensory is afferent and the motor is the efferent. It's as we said, it's the counterpart of the ankle jerk, so it's affected in S1 lesions. Less commonly, it can be done for the median nerve at the wrist while recording from the flexor carpi ulnaris muscle. When done in the lower limbs, we stimulate at the popliteal fossa while recording from the medial gastrocnemius muscle. I can find a unilateral delay or a total absence in the lower limbs, which not only suggests an S1 radiculopathy, it might be abnormal in tibial or sciatic nerve affection, in sacral flexopathy. That's why it has to be evaluated in the context of the other tests. There are two important remarks in the H reflex in particular, is that it once abnormal may not normalize, so we have to keep this in mind. So it's not very good in evaluating the follow-up or the follow-up of the case. It's also often absent in polyneuropathies or above 60 years of age. So we will talk about the limitations, but I wanted to say these a couple of points in the H reflex because they are mainly concerned with the H reflex. Sensory studies. Now we talked about the motor studies and the F wave and the H reflex. The sensory nerve testing, as you know, it's submaximal stimulation. We test the distal latency in milliseconds, the amplitude in this case in microvolt, and the nerve conduction velocity in meter per second. In the upper extremity, we test the median and the ulnar nerves and possibly the radial nerve. In the lower extremity, we test the superficial peroneal and the sural nerves. And it is very important to compare both sides, maybe the symptomatic side with the asymptomatic side, for instance. What's the importance of sensory studies? Why is it very important and indispensable? Because it is, if slowed, if abnormal, supports a localization distal to the dorsal root ganglion. And what we are having is mostly region proximal to the dorsal root ganglion. That's why I said sensory conduction is of great value, because it will be most probably be normal. If I find sensory slowing, I have to think about having another pathology and not a pure radiculopathy. So it's important. I want to do the test and I find it normal and it is of great value. Now we covered the main points for the nerve conduction studies, the motor, the sensory, and the F wave and H reflex. Now let's do the very important part, the electromyography or the EMG test. The EMG strategy is straightforward. It's very logical. I start with the relevant myotome. The patient comes, has pain here or there, pointing out to cervical radiculopathy or lumbosacral radiculopathy. So I start with the relevant myotome. The myotome I suspect to be abnormal on clinical grounds. I have to sample at least 2 muscles in the distal myotome, the proximal myotome, and in the paraspinal muscle. Paraspinal muscles should always be examined because they take their nerve supply very early from the root. So should always be examined. Do they have a pivotal role in leveling of the radiculopathy? The answer is no. But they have an important role in diagnosis radiculopathy. So I have to sample at least 2 muscles, distally, proximally, and the paraspinal muscles. Muscles innervated by the same myotome but by different nerves are very important to test. Why? To exclude mononeuropathy. You know the tedious tables we talked about? For each muscle, there was a nerve and a root value. Now I'm looking for the root value. So I find the affection is most probably in the following root or roots. But why not? It's an affection by the nerve, mononeuropathy. So I have to test muscles supplied by the same myotome, but different nerves to say, no, this is a radicular problem. This is a problem at the root value of the muscles, at the radicals supplying the muscles, and not at the nerve supplying these muscles, because they don't have the same nerve supply, although having the same root value. The proximal and distal muscles innervated by the same myotome are very important, as we said before, but here I want to tell you why. Because of the distal to proximal pattern abnormalities. These muscles are always worse peripherally. So maybe I'm talking about a peripheral neuropathy or a peripheral nerve lesion that's affecting the distal muscles more than the proximal muscle, and not about a radiculopathy. There are limitations and pitfalls about this point in particular that we will discuss at the end, but the policy has to be, I start with the relevant myotome, I test muscles innervated by the same myotome but different nerves to exclude mononeuropathy, proximal and distal muscles that are innervated by the same myotome to exclude the distal to proximal pattern abnormalities, and muscles innervated by myotomes above and below the suspected lesion. Why? To have some sort of leveling. Oh, I have these myotomes affected, one myotome above and one myotome below the affected myotome or myotomes. If normal, then this will be the lesion I'm talking about, or the lesion that I proved to be found. What is the solution if I have an equivocal EMG? I do it and I call my colleagues to take a look, and it's equivocal, I'm not sure. It's of value to compare in a contralateral asymptomatic muscle, especially if the patient is old. I'm suspecting why are his muscles a little bit neurogenic, the motor unit potentials, why is the interference pattern just a bit reduced. In this case, I can compare with a contralateral asymptomatic muscle and say, yes, this side I'm suspecting is definitely abnormal, or it is definitely normal. What's the case in post-spinal surgery? And post-spinal surgery, beware of the following. Paraspinal muscles will have fibrillation potentials and may continue to have these fibrillation potentials. So the patient had a previous disc herniation, for instance, did a spinal surgery, and now is coming for another problem or maybe for follow-up, then I cannot rely on the presence of fibrillation potentials in the paraspinal muscles. When I started my presentation, I said I can time the lesion. When did this lesion happen? There's a certain timeline or time course. EMG findings can be done at any point of the problem. I will, of course, have a referral from the referring doctors. I will talk to my patient, but I have to keep in mind that in the acute phase, I will just have decreased recruitment. If I'm expecting or wanting to see more abnormalities, then I have to do my test starting day 10 to day 14, because it's when the denervation appears. When denervation appears from day 10 to 14, it will appear in the paraspinal muscles first. So if I find the denervation potentials in the paraspinal muscles only, then I'm within the time frame of 14 days. From week 2 to 3, I will find the denervation potentials in the proximal muscles, supplied by the affected roots. From week 3 to 5, we agreed upon examining the muscles supplied by certain myotomes proximally and distally. From week 3 to 5, the denervation potential will be extensive to the muscles distally in the affected myotome or myotomes, of course. As the months pass, there will be re-innervation motor unit potentials. These are delayed, prolonged duration, maybe large in amplitude, prolonged duration, polyphasic motor unit potentials. Of course, the fibrillation potentials will decrease, and the recruitment will still be reduced, and it will be even more reduced than before. What are the limitations? When I'm telling you about the EMG, it sounds miraculous. I can know everything. I can know confirm the diagnosis. I can exclude other problems in the differential diagnosis. I can know the exact timing. No, there are limitations. Sometimes it is very difficult to localize radiculopathy if only a single root level is involved. Why is that the case? Because, as we said, there is an overlap of myotomes. So how can I point out or pick up a single root affection? The overlap will mask the affection, so the muscles that I examine, even if I examine correctly muscles in the suspected root level, the affection will be mild. The case will be masked. It will be difficult to diagnose. The most difficult level to differentiate were C6 from C7 roots. As we said, I will not go through it again. Don't be scared, but I wanted you to take a quick look of how it is difficult to have a muscle with a single root value. What other limitations do I have? False negative results are not uncommon. I have a radiculopathy, but everything, including the EMG, will be normal. Why? As I said, I do the test too early. The lesion is acute. I miss everything. I don't find an abnormality. The radiculopathy is purely demyelinating, so I won't find the fibs profuse to give me a clue about the affected roots. If the sensory nerve root is predominantly affected, so in this case, the EMG will be normal. Paraspinal muscles may be normal in some cases. Abnormal paraspinal muscles, as we said, are normal and very useful in identifying radiculopathy, but they won't help in the segmental level of the lesion due to overlap of their innervation. Fibs may persist in paraspinal muscles after spinal surgery, as we said before. Sometimes only the distal muscles may be abnormal in radiculopathy. I said before, we have to test proximally and distally for the same myotome. And if distally is more affected, I will suspect I'm not having a radiculopathy. I'm rather having another diagnosis. But in this case, I have a radiculopathy with distal muscle involvement mainly. These are limitations, these are pitfalls, are abnormally encountered conditions. Cases of spinal stenosis, which is not uncommon, something commonly seen, I can find few or no abnormalities with a lot of symptoms. The patient has a lot of symptoms and the EMG is normal or only slightly abnormal. Fibs in paraspinal muscles, which are important, as we said, and point out to the diagnosis, are sometimes present in other conditions. Proximal myopathy with inflammatory features. Paraspinal muscles with fibs. Disorders of motor neurons, as you had a lovely lecture with my colleague, Professor Lamia, last week. In this case, I will be having fibrillations in spinal muscles. Botulism, fibrillation potentials in paraspinal muscles, and in neuropathy affecting the dorsal rami. Another limitation, it was found that some fascicles within a myotome may be affected while others are spared. Some muscles of a myotome affected while others are spared. This means I had to do a generous muscle sampling because not every muscle I sample will be affected to me because not all the fascicles are uniformly affected. So I have to be a little bit generous with my muscle sampling, keeping into consideration the toleration of the patient. It's a painful thing, of course, and the time of the examination and the cost and everything, of course, has to be kept in mind, but we have to know that it's not always easy. Last but not least, patients coming for radiculopathy referred to us are frequently elderly patients. In the elderly, it may not be possible to differentiate mild chronic polyneuropathy, something they frequently have, from mild chronic bilateral L5 and S1 radiculopathy. Both will give me more or less similar. In the elderly, I can find sural and superficial peroneal abnormality or lower limit of normal in amplitude. So the sensory nerve action potential may be low normal. In this case, I can be mixed up if I find this, oh, it is not a radiculopathy, while this is a totally unrelated finding related to the age of the patient and not related to the fact that it is not radiculopathy. the patient might still have radiculopathy. Peroneal and tibial compound muscle potential amplitudes and conduction velocity are slightly reduced in normal above a certain age, and peroneal and tibial F and H are slightly prolonged. Anyway, we said that we will mainly depend on the EMG for localization. So these abnormalities in an elderly patient shall not make me diagnose another different diagnosis and exclude radiculopathy. It still can be radiculopathy. These are some suggested readings. Of course, our famous Preston and Shapiro, the chapter of radiculopathy in the book Electromyography and Neuromuscular Disorders. It's not the second edition, sorry, it's the fourth edition. It's the fourth edition, 2021. I highly recommend, and many others references, of course, for those interested. I hope I covered a little bit of this topic, the very important topic, and thank God I was sticking to my timing. Thank you very much for listening.